This echoes what I think we all know. We've teach a lot of people how to induce or introduce different therapies into patients, and we teach technical skills to many of our patients, to many of our colleagues. Jason and I spend a lot of time teaching these labs, engaging in fellows education. But treatment success for your patients is not end with a technically successful placement of an electrode or a needle. It begins there. And I think it's important for us to understand that that's an opportunity for you to influence the whole patient. We didn't make this up, but Jason and I sat in an airport together and we looked at the steps and lengths that we were taking to do research in our practice and to try and collect this data. And what we saw was torture. Spreadsheets, macros, and I told you, neither one of us is particularly computer literate. We were spending a lot of effort and still not getting great data. And well, we looked back and we went through every major expert consensus panel in the last 10 years. And it's basically universal that each of these recommends using first multidimensional assessments in the treatment, diagnosis, and outcomes management of our chronic pain patients, but also, and more importantly, the PROMIS system, or the Reported Outcomes Measurement Information System, which was developed by the NIH with about $100 million to generate a novel set of validated outcomes measures based on legacy measures, just with more accuracy and less questions, is widely recommended in all of these documents.
Yeah, we actually see that in the partnerships that we have with the device manufacturers in bringing neuromodulation to our space. When you look at the secondary endpoints of a lot of the studies, and there are 5 studies that really our space is built off of, there's a greater influence now on the secondary measures, knowing that's more representative of the patient's experience.
So our hope is that we can help you generate and utilize this data as a best practice in your clinic. And I want to take you on a quick tour of the PROMIS domains. The PROMIS system is once again a validated outcomes measurement language. It's a common measurement language that can be utilized across a whole host of different assessments. What Jason and I have decided in our practices and in our research is that our best practice is to use a PROMIS-29 as a universally relevant set of domains that measures fatigue, pain intensity, pain interference, physical function, sleep disturbance, anxiety, depression, and social participation. And then when we're performing certain procedures or patients have a certain diagnosis, we pair that with gold standard outcomes measures for that diagnosis, that procedure, or that treatment. And that can include things like an ODI, although we'll talk later how ODI can actually be derived and calculated and estimated from PROMIS-29, which is really exciting work, reduces your question burden dramatically. But things like a ZCQ for our minimally invasive spinal stenosis patients. ZCQs are also extraordinarily effective when you look at actually the questions you're asking to start to understand and titrate therapy in your spinal cord stimulation patients. And also to understand if perhaps this patient is developing a comorbid spinal stenosis that may or may not respond to their SCS. The important thing for PROMIS scores is that they're generalizable. The work has been done to validate this across the US general population so that you can easily stratify your patients in a way that makes sense. How do they compare to the general population? And at Celéri, we want to give you tools to be able to drill that down and allow you to track your individual patients longitudinally and also analyze your population of patients in a way that has never really been available to pain physicians before. One of the other things that we've found to be extraordinarily important is moving away from that linear pain score. And to do that, we, again, looked to work that has been done in our space. In 2014, the NIH Research Task Force for Low Back Pain put together an interesting concept of utilizing something called the pain impact score in patients with chronic musculoskeletal pain, is also with chronic low back pain. The pain impact score is a single-digit number. It's derived from a pain intensity score of 0 to 10. PROMIS pain interference raw score, 4 to 20, with 4 being the lowest, and the inverted PROMIS physical function, meaning we take the inverted scores so that they're aligned. Because if you have very high levels of pain interference, that's a negative attribute. That's not a good thing. But if you have high levels of physical function, that's a positive attribute. That's a good thing. In order to align those, the physical function domain is inverted in this calculation. Pain impact score goes from an 8 to a 50. An 8, no impact. 50, severe or high impact. It's estimated that somewhere between 11 and 20 million Americans live with high impact pain based on the 2018 US Health Outcomes Survey. A minimally important difference that has been born out of the validation work for the impact score notes that 3 points on that scale is what we can call a minimally clinically important difference. And here at Celéri, we're working to validate that in other conditions, and more specifically in very narrow patient populations that we treat.